Welcome to Healthline 3. I'm Jade Balexa. Thank you for joining us. Besides skin cancer, prostate cancer is the most common cancer in men. That's according to the American Cancer Society. Treatment has come a long way. Hematologist and oncologist Samip and radiation oncologist Sanford Katz of Willis-Knighton Health System are here now. Thank you, doctors, for joining the program.
Thanks for having us, Jade.
Absolutely. Well, remember to call in with your questions at 318-219-4569. We'd love to hear from you. Well, Dr. Master, can endocrine therapy help in treating prostate cancer?
Certainly. Prostate cancer is the cancer that gets fueled by the testosterone, the male hormone. So endocrine therapy, or the hormone blocker therapy, is kind of the backbone of the prostate cancer. And a lot of other treatments for advanced prostate cancer are kind of layered on top of this endocrine or hormonal therapy. So yeah, that is one of the main things that we treat these prostate cancers with. There are some things on the internet that kind of puts people down against it, but it is very important. It is manageable. I have had patients who have been running 10Ks and taking care of their grandkids on hormonal therapy, living for years. So it's manageable, and it is very important for prostate cancer management.
So tell us, what are some of the recent advances in treating prostate cancer?
Well, it's a very exciting time right now, Jade, because targeted therapy or individualized therapy is really all the rage in a lot of different cancers, but particularly in prostate cancer. And what we're able to do is we're able to selectively deliver the treatment not only to the prostate gland, let's say, but to some of the lymph nodes or wherever the prostate cancer may have spread. But before we even do that, we have to first discover the prostate cancer, and we want to find it at its earliest stages. So screening is really important. And how we treat prostate cancer really depends upon how advanced it is. So we obviously, whenever you're talking about cancer, you want to catch it early. And the best way to do that is with screening. And the way that we screen typically is with a PSA test, which is a blood test that your primary care physician can order. And so when we're talking about treating, let's say an early stage prostate cancer, targeting that cancer, we may just need to treat the prostate gland and not need any systemic therapy, not need hormonal therapy. And in those cases, typically the primary treatments are surgery or radiation, both of which just target that prostate very specifically.
And Dr. Master, who is at risk for prostate cancer?
Well, the risk of prostate cancer happens in men as they grow older. So age is one of the risk factors. Family history is important. Like if you have a brother or a father had prostate cancer, then your risk increases, especially if they had it when they were less than 60 years of age. Ethnicity is another big thing. We have seen more prostate cancers in patients of African American descent. Okay, so those are some of the risk factors. And then there are some genetics, like if you have your family history of breast cancer in your female relatives, those are all the risk factors that can cause increased risk of prostate cancer.
So there is precision medicine. So let's talk more about individualizing the care. When does one need to do that?
Right. So we can actually determine the risk factors that people have for having disease perhaps a little bit more advanced. And then we have imaging that's very, very precise and very sensitive to determining if the prostate cancer is localized or perhaps it's a little bit more advanced and needs more aggressive care. The other thing that we have now is the ability to test specifically the tumor and to look for specific mutations in that tumor that would predict for a more aggressive course. And then in response to that, we can design our treatment to be perhaps a little bit more aggressive or a little bit more specific. There's also tests even in the urine. You can check the urine, and that can help to predict the likelihood of having a more aggressive cancer, and that can even help the urologist determine whether or not someone needs a biopsy or doesn't need a biopsy. So being able to determine exactly what kind of treatment that particular patient needs enables us to not only treat the cancer better and give greater chances for cure, but also to limit the side effects as well of treatment so that people don't get, let's say, more aggressive treatment than they need, or let's say they don't get treatment that's not aggressive enough.
Wow. And so genetics are being used to tailor different prostate cancer treatment strategies too. How does that work?
Well, we're talking specifically about the genetics of the tumor, because the tumor itself has mutations which made it turn into cancer in the first place. And so depending on what those genetic mutations are, that can tell us how aggressive the cancer is and how we should treat it, whether we need to add hormone therapy, as Dr. Master discussed, or whether we don't need to add that, whether we need to, maybe we need to not do surgery because the likelihood is that cancer might be a little bit more aggressive and may have spread. So the genetics of the tumor is very, very helpful, and usually those mutations are only found in the tumor, not inside the patient. So we don't need to check the patient's genetics, just the tumor's genetics.
Oh, I see. Okay. So with hormone therapy, Dr. Master, can that delay the progress of the tumor?
It all depends on the stage of the tumor and where we find it. Like as Dr. Katz said, if it's a very early stage, they can get away with surgery. That's possible in low risk. But when we go to like localized, but localized, but still having high risk features, then we can definitely add hormonal therapy to slow down and cure the cancer. When we go to the advanced stages, that's when they need hormonal therapy for pretty much everyone to slow down the process and control the cancer.
Do you see hormone therapy preventing prostate cancer at all?
I don't think so. There is any hormonal therapy that can prevent prostate cancer. The best way to prevent is there is no such preventive measures, but there were some data that heavy weight or obesity can increase the risk. So that's something, a healthy lifestyle would be something that I would like to promote. But if you have a family history, if you are at a higher risk, talk to your GP and get screened, as Dr. Katz said.
Mm-hmm. So let's move right along here to AI. Does that enhance prostate cancer diagnosis and treatment?
Well, I wouldn't say AI or artificial intelligence necessarily helps, but we do have certain paradigms or guidelines that we use that are standardized. And AI would perhaps follow those guidelines because those guidelines are all based upon studies, well-controlled national studies, and experts set these guidelines. And we all try to follow them, but at the same time we have to tailor them to the patient specifically. The guidelines that we follow are really very helpful because we're able to characterize people's cancers as either, let's say, very low risk, which might not need immediate treatment. They might be low risk, which could be observation or treatment. And then, if they have, let's say, an intermediate risk, a high intermediate, lower intermediate risk, perhaps in those situations, they definitely need treatment. And surgery or radiation therapy are both very good treatment options. And in both cases, again, we can really target that prostate really specifically. And generally, the side effects, particularly when we're talking about radiation, very, very limited. Patients come for just a short time each day, maybe 30 minutes. They'd come for a number of treatments that may last a number of weeks. But most of the patients are able to work, carry on their regular activities with really very little interference in their daily lives. When we get into the more advanced cancers, that's when we're talking about integrating hormone therapy or certain medicines. Mm-hmm. So it's the guidelines that are really very, very important, and AI may be helpful in helping to select out those patients who perhaps are a little bit on the fence. Maybe they're somewhere in between, like an intermediate or a high risk, and we're not, you could go either way, but the AI might be able to help us a little bit with some of the specifics, like the genetic testing that we talked about a little bit earlier.
Mm-hmm. So, and MRI technology has certainly evolved. What type of MRI is being used in prostate cancer management?
Yeah, well, as a therapeutic radiologist, I guess I'll take this question. Yeah. So the MRI is very, very helpful in a few ways. One way is it helps to direct the prostate biopsies. So when somebody tests positive, let's say on a PSA, which is not diagnostic, just it helps us to zero in on those patients who might have prostate cancer. The next step is a biopsy. And so you want to make sure that when you're biopsying the prostate gland that you're biopsying the right spots and that you don't miss. So we generally will do multiple biopsies. That's done by the urologist. But the MRI can help them because they can see specific areas in the prostate that might be abnormal, and then they can direct extra biopsies to those areas. So it really helps with the accuracy of that biopsy. The other way it's very helpful is for those people who are appropriate candidates and opt for observation, which means that their prostate cancer is there. It may not be growing that quickly. Maybe they're older, they have other health problems. There might not be an immediate need to treat that prostate cancer, but we're going to follow it very, very closely. And one of the things that is often done is to use the MRI along with the blood tests and whatnot, the PSA following it, and maybe additional biopsies, but using that MRI to also really image that prostate gland and make sure nothing's happening during that during that observation period.
Okay. So tell us about therapeutic radionucleotides and how they're used to treat cancer. What are they and how are they administered?
Yeah, so first off, one of the most exciting things in prostate cancer now is the ability to specifically look for prostate cancer cells that might be circulating around in the body and deposited in other areas, whether they be in organs or in bones, where previously we didn't really have good scans to know whether the prostate cancer had spread. And so now we have something called a PSMA test, which is a special type of scan, which has a little radioactivity attached to it, and it's an antibody, which means it's a special type of protein that targets the prostate cancer cell specifically. And so we start off with this, where we can look and we see if there's any cancer in other parts of the body. Now, that's usually an indication that the person needs systemic therapy that their master could administer and oversee. And those medicines he can talk about in more depth. But sometimes we need to go a little extra, and we can use this targeted radionucleotide, which is basically radioactivity, but in a very, very safe way. We can deliver it just to the cancer cells. And the way that we do that is we use the same technology as that imaging test, that PSMA test, which has that antibody, which is a protein that looks for the prostate cancer, has a little radioactivity that we can see on imaging. Well, the difference with this, and there's a drug called Pluvicto, which is a very exciting new drug. And what we do is we use the same type of targeting, except the radioactivity that we attach to that antibody is now not for imaging, it's for treatment. And so that higher dose radiation then targets the cancer cells, and it can really help with the systemic therapy in killing those cancer cells wherever they may be, and at the same time not affecting any other organs or other cells in the body. So it's a new advance, and it has dramatically improved survivals and what we call disease-free survival, meaning no evidence of progression of disease. So it's really been a major advance recently in selected patients.
How do you incorporate the medication into this, Dr. Master?
So specifically talking about the advanced prostate cancer, when we have a patient who comes in with an advanced prostate cancer, as I said, the hormonal therapy is kind of the backbone at that time. And then we'll look at the patient, see what his medical problems are, age and other comorbidities, and how much is the prostate cancer affecting him. If he has a lot of cancer deposits, then we'll offer him chemotherapy. If there is not a lot of disease, then we can even do hormonal therapy. That kind of adds to the effect of the androgen suppression that we're already doing. About 95% of the testosterone, that's kind of the fuel for the cancer, it's produced in the testicles. So we suppress that chemically. But when they are advanced, we can add some drugs that kind of add to the effect of that chemical castration, and we can add that to the regimen. And that's what we call as castrate-sensitive disease. And there is a good response rates. All these treatments that we have, they have shown in the well-controlled studies that they make people live longer with a good quality of life. One of the things with prostate cancer when they're advanced is the prostate cancer loves to go to the bones, all right? And when it goes to the bones, it hurts. And these treatments are very well directed to help control the pain, because the quality of life it's very important for these patients, especially as the radioligands that Dr. Katz was talking about. They are very helpful in controlling the bone pains that these patients might go through.
How often do people get the advanced form of prostate cancer? Is this pretty common? Do you all see this a lot?
Well, I think it used to be more common before the PSA test. before we could screen people and identify early stage disease, people didn't know they had prostate cancer until it showed up somewhere else, where, as Dr. Master said, it ended up in a bone, and they either broke a bone, broke their hip, or had a lot of pain, and then it'd be investigated and say, oh, you have prostate cancer, it's already advanced, it's already spread. We see less of that now because people are being really good about screening with that PSA test. And so we generally find these cancers when they're very early. So in people who are screened, it's very rare to find advanced disease. Now, sometimes people can develop advanced disease, after, let's say, they had initial treatment. So let's say someone had surgery and they were doing well, but the cancer came back, or it had maybe been a little bit more advanced than initially thought. Unfortunately, down the road, it can sometimes progress and show up in other places. But I would say in my practice, it's, when I screen people, I would say it's, sometimes I'll find locally advanced disease, but it's unusual for me to see more distant disease or metastatic disease. Now, those are the patients that I see, but Dr. Master may see a different population.
What are you seeing in your practice, Dr. Master?
The patients come to me when they are mostly advanced, like advanced disease. And I see quite a lot of those patients, unfortunately. But, as you know, there are about 200,000 patients diagnosed with prostate cancer in the US on an annual basis, and about 30,000 die from it. So there is a lot of prostate cancer in the community, but as long as, we treat them early, catch them early and treat them early, we can cure it. When they are advanced, that's when they come to the medical oncologist, and we can offer treatments to control the cancer, control their symptoms, and make them live longer.
Mm-hmm. How do you guide patients in making informed decisions about their treatment options? I'll let you go first, Dr. Katz.
So that's an excellent question, because when people get diagnosed, they have lots of options, and I mentioned earlier about the guidelines. When patients are found to have early stage disease, potentially curable disease, the standard treatments are either surgery or radiation therapy, both of which are very effective, and generally they're comparable in terms of cure rates. Now, surgery is a big deal. You have to be relatively robust, you have to have good health, you have to be relatively young and healthy, and not have a lot of other things that might make surgery a little bit more risky. But for those patients who either are not good candidates for surgery or opt against surgery, then they come to me, and we can talk a little bit more about radiation therapy as their primary treatment. But for patients who are otherwise good surgical candidates and good radiation candidates, usually what happens is we have a conversation and we say, hey, these are the potential benefits of doing radiation. These are the potential side effects. Surgery offers these potential benefits and these potential side effects. And depending upon what that person values the most, they may opt to go one route or the other. So it's important that patients have choices and that they're presented with the choices that they may have, and then they make that decision. Because again, we don't treat cancer, we treat people with cancer, and everyone's situation is a little bit different. I've had people who, let's say, they're a long distance truck driver and they can't come back and forth every day for radiation. For them, they may want to take a short period of time, be off, have surgery, recover, and then go back and work. I've had other patients that said, you know what, I don't want surgery, I like playing golf. I want to play golf every day, I want to play tennis every day. So for someone like that, they can stay active, doesn't need to interrupt their routine for them to come for treatment, and they may want to go for radiation. So it's oftentimes really up to the patient in terms of what is best for them.
Mm-hmm. And tell me, Dr. Master, how do you help the patients make informed decisions? I mean, does the hormone therapy make them feel bad, or what is the patient experience like?
So again, in advanced prostate cancers, there are multiple treatment options available, ranging from chemotherapy to endocrine therapy, radioligands, and it all depends on the patient's stage, aggressiveness of the disease, and as Dr. Katz was mentioning, the specific molecular cancer profile. Because as we have dived deep into these molecular profiles of cancer, we have found that there are certain drugs that we can use specifically for that patient, known as PARP inhibitors. Those are the ones that are more geared towards one kind of patients. So we go over the treatment regimens, side effects, schedules, and what are the things that the patient is expecting from them. Like, I have some patients who have a lot of disease, but they're like, doc, I'm not going to take chemotherapy. That's their thing. And I was like, and then we can offer the other hormonal options, maybe radioligand options. So, and we tell them, okay, these are the side effects, these are the benefits you get. This chemo or this treatment can make you live this much longer. And once we present with all the options, we make them have the best decision that fits their life, because we want to treat the patient, not just the cancer.
Mm-hmm. Exactly. I like that motto. You're treating the patient, not the cancer. Well, I mean the patient with the cancer, rather.
Yeah.
Yeah, exactly. So tell us, do you see the synergy between various advanced treatments shaping the future of prostate cancer?
Yeah, it's really, the paradigm has changed a lot. We used to talk about just either localized prostate cancer or distant disease. The localized prostate cancer, let's say, was the wheelhouse for the radiation oncologist. So, but once the prostate cancer had spread to other parts of the body, then it became something that the medical oncologist would really oversee. But now we're seeing synergy. We have synergy even when we're doing localized treatment with radiation therapy, where we might incorporate hormone therapy in those more aggressive disease. But even in the setting where someone might have more advanced disease, let's say distant disease where they need chemotherapy or long-term hormonal therapy, there's also now a benefit to treating the prostate cancer, the primary prostate cancer, and there's a benefit to doing that even if the disease is more distant. So we're actually now incorporating the radiation and the chemotherapy together. There are times when even if somebody has distant disease in just a few places, we can use radiation to target just those few places, allowing the chemotherapy to work better, addressing the small amounts of cancer that might be circulating, keeping it from showing up in other places, while the radiation targets those areas with just a little bit more deposits. So there is a lot of synergy now between the chemotherapy, the systemic therapy, and the radiation therapy in both the localized disease, the more locally advanced disease, and in the distant advanced disease.
Yeah, there's so much happening with this technology. So remember to call in with your questions at 318-219-4569. We're more than halfway through the program, so you have time to call. And tell us, collaboration among medical professionals is vital. How do you, Dr. Master, work with other specialists to provide comprehensive care for prostate cancer patients?
So when we treat a patient with prostate cancer, he needs a urologist, a radiation oncologist, and a medical oncologist. And obviously we also want to involve their primary care as well, because there are other medical problems that they need to monitor during that time. So once we have a patient with a new prostate cancer, we do talk. If I have a patient, I'll pick up the phone and call Dr. Katz or the urologist and say, hey, we have this patient. Would you see him? Will you see? And let's come up with the best plan that we can offer to the patient that's specific for his needs. So we do work together very closely on all the prostate cancer patients to get the best for that patient.
Mm-hmm. And Dr. Katz, it seems with the evolving landscape of prostate cancer management, how do you ensure that your practice stays up to date with the latest developments?
Yeah, well, that's really dependent upon the clinicians. To be conscientious enough to keep up with the literature, to read the studies, to keep up with the latest technologies. And at Willis-Knighton, that's one of the things that we're well known for, not just locally and in the region, but nationally, that we're at the cutting edge and we keep up with all the technologies. In my own department, we've always been one of the first in the country to deliver the most advanced treatment, and that started back going, let's see, to early 2000, late 1990s, where we were one of the first places to deliver something called IMRT, or intensity modulated radiation therapy. Everything we do in radiation oncology is about targeting the tumor and minimizing the radiation to the surrounding structures, because that's where the side effects come in. So if we can limit the radiation, then patients have less side effects. We can give higher doses, cure more prostate cancer. So it started with, let's say, IMRT back in the late 1990s. From there, we've moved on, and we've had imaging that we use to follow the patient's prostate gland, make sure we know exactly where it is so we can be even more conformal. And then we were also one of the first places in the world to get proton therapy. Now, proton therapy is a special type of radiation which, instead of using photons, uses particles, subatomic particles. And it's been around, it's not new, it's been around since, I guess, 1960s, but not really necessarily widely available for use in treatment of prostate cancer and other cancers. And so Willis-Knighton was the first place in the world to get a single room, community-based proton therapy unit. And the advantage of proton therapy is it's very, very specific. It doesn't have an entrance and an exit, let's say, dose of radiation like other types of radiation like IMRT. It is very specific in that it only goes so deep, and it doesn't deliver radiation on the way in very much, and doesn't deliver any radiation on the way out. So the proton therapy enables us to be that much more precise, keep the side effects down. And we have a commitment at Willis-Knighton, and we always have, to make sure that we can deliver the most advanced, best radiation therapy available. And we've gotten a lot of support from our administration over the years, and so this is one of the reasons why I'm not originally from Shreveport. I'm from the Northeast, but one of the things that brought me down here was the fact that Willis-Knighton was so committed to delivering advanced, state-of-the-art care, and it's kept that commitment the whole time I've been here. And so this is where I'm going to stay, and I love practicing here because I can offer my patients the best treatment.
That's pretty amazing. And Dr. Master, tell me how you stay up to date with the latest developments.
About reading, I look up the web and our medical journals. Obviously, talking to my colleagues also helps me. So it's a way to just reading journals. I like to teach as well, and that kind of helps me keep up to date. So yeah, it's an ongoing process, learning every day.
Well, how are these advanced therapies impacting patients' quality of life? I mean, you mentioned the proton therapy. How do patients experience that? I mean, what do they tell you?
Yeah, so quality of life is everything. When we're talking about treating cancer, if we treat the cancer but the person's quality of life isn't good, we haven't necessarily really done them a really good service. So the thing about radiation in general, as I said earlier, is that we really want to minimize those side effects. Typically, when we're talking about radiation side effects, we're talking about, let's say, irritation to the urinary system, let's say burning on urination, or maybe getting up a little bit more at night to urinate, maybe a little more urgency. And then we also watch out for dose to the rectum, which might result in, let's say, some increased bowel movements and things like that. We have some techniques now that enable us to actually know exactly where the prostate is every day, make sure it doesn't, that if it's moving, we can see where it is. We also are able to actually kind of displace or move the rectum out of the way. And those are some things that we do just specifically in each particular person. And then we use the technology to avoid those other areas. And as I said, proton therapy is even more conformal. So in my experience, patients have very little side effects. And again, they get through, and their long-term side effects are very minimal. During radiation, many of them don't even have any side effects at all. And so the quality of life typically is excellent, both short-term and long-term.
And what about you, Dr. Master? What advances are you seeing in the endocrine side of things?
So, we knew from a long time that this testosterone produced by the testicles is the suppressing that, or chemically or surgically, is the backbone for the treatment. Then we have new drugs available right now that kind of goes and targets the receptor where this testosterone is supposed to work, and so that whatever little bit of testosterone is produced anywhere else in the body doesn't affect the patient. There are some these drugs are very targeted to that receptors and prevent any other side effects, but cause the prevention of hormonal effect of the cancer. Now, as I was mentioning about more of a PARP inhibitors, these are the pills that are specifically approved for patients with certain genetic mutations in their cancer or germline. And now we are combining them with the hormonal therapies, and we are seeing excellent results with a good tolerance. So that's something very specific for that kind of a population. So those are the new things in the prostate cancer I'm very excited about. Obviously, we have the chemotherapy and the other things that we can offer.
Wow. Well, this 30 minutes has gotten away from me. There's so much more we could talk about. Please come back on again so that we can cover more about these advances in prostate cancer. I've enjoyed having you both on, Dr. Katz and Dr. Master. This has been so enlightening, and you guys join us again for another Healthline 3. And there you go, after midday, and we'll let you know when we have another Healthline. These doctors were great. Have a good one.